Dr. Jason Ong, who is Director of Behavioral Medicine at Knox Health, a healthcare technology company that I think is based right in Atlanta, right, Doctor? So he has two reasons to be here. Dr. Ong is also the adjunct associate professor at the Department of Neurology and Center for Circadian Sleep Medicine at Northwestern University. He has a PhD in clinical psychology, and his primary research interest is in developing non-pharmacological treatments in sleep disorders. So now let me introduce Dr. Ong.
15 minutes for questions.
All right. Thank you so much for the kind introduction, Paul, and good morning, everybody. It's good to be here. Good to see everyone in person. After being away from each other for so long here, it's good to slowly get back into connecting in person. So as Paul described, we're going to have two sessions today. So this first one is about the science of psychosocial interventions. What I'll do here is explain some of the methods and the evidence that we've gathered thus far in terms of why we need these programs and what we've done thus far in terms of the research evidence for them. And then the second one will be what I hope is going to be a little bit more fun. So I'm going to be talking about some of the tools, some of the techniques that we've been using in these programs to give you a little bit more of an idea. I'm going to try to make this interactive as well as we go along. So hopefully we'll have some fun with that. Okay. All right. So let me see here if I can... All right. Okay, good. So just a little housekeeping stuff first. So these are my disclosures. I don't think any of the material I'm presenting today has any conflicts with these disclosures. Most of this work was done when I was at Northwestern University in academics. Okay, so I just want to start with this, which is why do we need a therapy just for people with narcolepsy? So this was a question that came up a lot for us as we were trying to plan for our research studies and writing proposals. These are grant proposals, so this goes in front of other scientists and our peers. And although at this time, by the time we got to this point, I had talked to plenty of patients and been to conferences, so I knew the answer to this, and I'm sure you guys know the answer to this, but we had to convince the scientific folks why we need another therapy, because they ask questions like, well, why can't we just give them antidepressants? Or why can't they just go see a therapist? What's different about people with narcolepsy? So we had to answer these things. So the first thing is this issue about quality of life. And I think with most of this, I'm going to be preaching to the choir, but just so everyone's on the same page. As you guys know, pharmacological treatments can reduce hypersomnia symptoms, but there's still this quality of life remains really poor. And there is the impact on functioning, on patient burden that still is not solved by the pharmacological treatments. And in particular, it's psychosocial functioning that's very poor. So we're talking about emotion regulation, interpersonal relationships. The studies have found that people with narcolepsy have about 2 to 4 times the number of psychiatric conditions. So we're talking about things like depression, anxiety disorders. So 2 to 4 times compared to control cases. So in these studies, typically it's somebody who is matched with someone with narcolepsy. So you can see that these conditions occur at a much higher frequency among people with narcolepsy. So as we got into this, one of the first studies we did was just a survey study, just to kind of get a sense of what's out there and what people are interested in. So this first study is an online survey we did. We had 371 people. And this first set of data is really just to kind of confirm that our sample is consistent with what's been reported in the literature. So not surprisingly, you can see that there's very high endorsement of symptoms. Most of these are cardinal symptoms of depression, especially sad mood and loss of interest. So these are kind of the two cardinal symptoms of a depressive disorder. Other things like irritability, social isolation, difficulty with concentration, and so forth are also symptoms. And then we have anxiety and worry. So keep in mind these are symptoms. These aren't people with a diagnosed condition of depression or anxiety. But you can see that the rates are really high, about 60 to 80%. So then the other thing we wanted to know is behavioral strategy. So here, this gets into some of the things that I was interested in. So what we put together is just a list of things that we had heard, some other common things that are often recommended, and a couple of other things like mindfulness and yoga that I was personally interested in as well. And again, as you can see here, not surprisingly, things like taking daytime naps and scheduled sleep time, a large proportion of people, about 80 to 75% of people were using these strategies. When it comes to caffeine, exercise, diet, so other things related to lifestyle issues, quite a bit of people were using that, about half to 3/4. And then about like 1 out of 5, about 20% were using other techniques such as mindfulness and yoga. I thought that was kind of interesting. And really not a lot of difference between people with narcolepsy and idiopathic hypersomnia. And I should say that was a fairly common theme that, people, there were maybe a few subtle differences, but generally speaking, the disease burden was quite similar between narcolepsy and idiopathic hypersomnia. But what I thought was most interesting is down there at the bottom. We also asked, in addition to just what are you doing, how did you learn about these things? So as you can see, the first thing, trial and error. So this, I think, is 78%. Sorry, it's a little hard to see from my angle. So about 3/4 of people were just winging it, right? That doesn't sound very scientific. Internet was next, I believe. I think that's 44%, if I can see that correctly. So again, another really reliable source, looking online. Other patients, so word of mouth, that was 38%. It wasn't until we got to like 4th place and 5th place where we had sleep specialists and physicians. That was like 33% and 24%. So you can see like people were just sort of learning this like basically on their own, talking to other people, doing like a Google search or finding things on Reddit. So to me, what I was thinking is that, look, we need, we need to figure out if these work or not. We need a scientific foundation to know whether or not this works. And if it doesn't, then we should stop recommending these things. So then we took a deeper dive, and we wanted to look beyond just a number. So, okay, we know a lot of people have these issues, but how? How does narcolepsy impact quality of life? And so we did what we call a mixed method study. So people are used to quantitative data, right? These are numbers. There's also qualitative data. So this is when you ask people open-ended questions. And we actually look at common themes in terms of how people respond. So this is actually something that they do in marketing. And we started doing that more in terms of treatment development and other areas where getting that richness of the qualities are very helpful. And I think in developing something like a psychosocial intervention, that's particularly useful. So what we did is we ran these focus groups where we asked people open-ended questions. We like to do them in groups because oftentimes if somebody's talking, somebody else can piggyback on it. And so it provides a more rich response set there. So I just wanted to show you some of the things that we found from this. So, when it came to the quality of symptoms that affect health-related quality of life, it wasn't just the fact that people were sleepy. It's the fact that they were constantly sleepy. So if I can see this quote here, this is a nice one where someone said, people have the perception that if you have narcolepsy, you just feel you feel fine, and then you randomly fall asleep. They don't understand that it's a constant thing. Okay, so it's the quality of sleepiness, not just sleepiness itself, and you can't get that from a rating scale. Okay, and then when it came to cataplexy, it wasn't just the fact that we're having cataplectic attacks; it's the unpredictability of them. Okay, so this is another nice quote. Basically, what made me go downhill was with my cataplexy. I was walking on campus, and there was a spot where there wasn't anything to hold on to, and I had an incident in which I went all the way down to the ground. Even to this day, I still avoid that area, and has really taken a lot out of me. Okay, so just kind of illuminate a little bit more about like the hows of the quality here. In this case, it's the unpredictability of cataplexy, and the avoidance has led to a lot of anxiety. It sounds like for this person. And then there's stigma and self-perception. So I think, again, you guys know this. You can tell me better than I can tell you, but narcolepsy is poorly understood by the general public. There's a lot of negative social stigma, so oftentimes people, might be called lazy. When you see characters in movies, often they are like a comical character. They're made fun of. Some people are even skeptical whether or not narcolepsy is a real condition. This person said, I feel like people think of it as kind of a joke, and they're like, oh, that sounds good. I wish I could sleep all the time, Well, that's pretty insensitive if, you're constantly sleepy. And then there's negative effects on self-esteem and self-efficacy. And in case you're not clear about these terms, so self-esteem means how you feel about yourself, your own sort of like well-being. Self-efficacy is really more of a sense of whether or not you feel capable of accomplishing things. Okay, so both self-esteem and self-efficacy are important for mental health. And so here, some people were hesitant to tell others about being diagnosed. Some people even felt that they were ashamed of having narcolepsy, that it was an invisible illness. And many people mentioned that they felt a lot less capable of being able to do things. So you can see the effects here on self-esteem and self-efficacy. A couple quotes here. I get tired trying to explain why I'm tired all the time. That came up quite a bit. I tend to focus on who I want to be, but I need to focus on who I am. Okay, so you can see here some of the impact. So then we also asked about challenges with current treatments. Many people said that they met with their sleep doctors on a regular basis, about every 3 to 6 months, so that's good. And that generally this was good for talking about things like medications, changes in symptoms, but oftentimes there wasn't really much time left over to get into some of the emotional aspects, the psychosocial issues, and so forth. This person said, my sleep doctor listens to me, but does not provide advice on psychosocial aspects. There was also quite a bit of dissatisfaction with mental health providers. So I'm a clinical health psychologist by training. So this sort of hit home because a lot of people said that that their mental health provider didn't understand narcolepsy, really had no idea, and so they tried to, in many cases, implement a treatment that might not be suitable for people with narcolepsy. And then this reduced rapport, so that connection with the therapist, and really hindered their ability to connect and trust their therapist. And, in any kind of psychotherapy, that connection is really vital. This person said, I get so frustrated because I just spent an hour in therapy explaining what narcolepsy is. Okay, so that really shouldn't happen, right? And then challenges with accessibility. So in some cases, the narcolepsy symptoms like sleepiness created challenges with the appointment attendance. So this person said, I've lost doctors because I couldn't make it. I would wake up, or I won't wake up, and if nobody calls me, and I turn all my alarms off. Okay, so you can just see some of the challenges there, just even getting to a provider. And the last thing I wanted to show you here is a recent update by the American Academy of Sleep Medicine, where they updated some of the treatment guidelines. And I just highlighted this over here. I'll see if I can see it. It's a little bit small, but it says, let's see if I can, okay, bear with me here. Let me turn over here a little bit. So it says that clinicians should be aware that, hold on, bear with me. Let me see if I can get a better angle. Clinicians should be aware that additional non-pharmacological management with workplace or educational disability accommodations, sleep hygiene, and cognitive behavior therapy / psychological support is often needed to optimally treat people regardless of drug treatment use. So the key there, from my standpoint, is that last part, is needed to optimally treat people. So that sounds to me like right now we're not optimally treating people with just medications. So with all of this is my conclusion, that right now we have hypersomnia treatments that can reduce sleepiness. They're pretty good at that. However, there is an unmet need for a therapy that's relevant to people with narcolepsy and people with idiopathic hypersomnia that can improve quality of life and can reduce depression and anxiety. Okay, so that's basically the summary there. So what I want to show you here in the next few minutes is some of the work that we've been doing to develop a there's a couple different programs that are kind of in progress here. This one is a treatment development study. So you can think of this as sort of a test of a proof of concept, if you will, or whether or not this idea of a cognitive behavior therapy for hypersomnia should be tested further. So sort of a, if you build it, will they come? Okay. This is the study was actually designed using remote delivery, so using telehealth, and we actually did this before the pandemic. As it turns out, with the pandemic, we were a little bit ahead of the curve, but it was good that we did this because we thought that this would improve the outreach. Also, it responds to some of the things that we heard about challenges with getting to appointments, so we thought this would be helpful. And this is basically like the program. We have it in modules because we realize that symptoms vary from patient to patient, and also we're combining narcolepsy and idiopathic hypersomnia in this case. So there are differences between these two conditions. So this would allow clinicians to pick certain modules that are most relevant to the patient and their symptom profile so that it's more customized, okay? And the other thing I want to point out with this is that CBTH is designed to be an adjunct. And in fact, to enroll in our study, you had to be on current treatment. So medications, you had to be on a stable dose of medications. So this is not a substitute for current standard medical treatments for narcolepsy or idiopathic hypersomnia. Okay, so there are other forms of CBT for depression or anxiety, for example, that are substitutions for antidepressants or medications for insomnia, but this one is not intended to be that way. Okay, so I want to make that point clear. And then I just wanted to show you some data here. So one of our main outcomes was depressive symptoms because we wanted to know if our program could improve depression. And so the PHQ is a very common measure for depression. And what you see here is from baseline to post. Oh, and I should say that we gave this intervention both as a group format. These are small group formats of about 4 to 6 people, as well as individual, because we weren't quite sure which format would be best. So as you can see, in both the group and the individual, we got reductions in the depressive symptoms as measured by the PHQ. It was a little bit stronger for the group version. And then on the right side there, you can see we had what's called a clinically significant response. There's a certain benchmark. What we were trying to aim for is that we wanted to get at least half of the sample to have this clinically significant reduction. We were able to achieve that in the group. We fell a little bit short here in the individual. So all of this suggests that the group-based version might be a little bit more conducive to improving depressive symptoms. So we also had other patient-reported outcomes. This comes from a system called the PROMIS. And what I just wanted to point out here, looks like the box got a little bit distorted, is that the one that really sticks out here, so the higher it goes, the greater the impact. So you see here, it's actually the GSE, which stands for General Self-Efficacy. And I was really pleased to see this because if you remember what we talked about before, that all the impact on self-esteem and self-efficacy, we're able to get people to increase their self-efficacy from the beginning to completion of the treatment. So that gives us some ideas that this seems to be having a psychological mechanism, if you will, sort of the active ingredient seems to be improving self-efficacy that's leading to some of the reductions in depression that I showed you earlier. Okay. So just a little bit here about our mindfulness program. So, you might be familiar with mindfulness. Basically, it centers around awareness, non-attachment. It's kind of a stress reduction technique. And then self-compassion. That's really the one that we thought would be most relevant for people with narcolepsy. I have the Dalai Lama here because a lot of the philosophy of this approach comes from Buddhism. But it's really the self-compassion that we were interested in. So we had this program. We call this project ASCENT. It stands for Awareness and Self-Compassion Enhancing Narcolepsy Treatment. And much like that earlier study I showed you, this is also one of those proof of concept treatment development studies. In this case, we were trying to see like what kind of dose, in other words, how long of a program we should have that would be most effective and tolerable for people with narcolepsy, because the standard is 8 weeks, and it's usually 2 hours for each of these classes. They're sort of done in classes, and we weren't sure if people with narcolepsy would quite have that stamina, so we thought, well, maybe we should do a crash course, shrink it down to 4 weeks, and see if that works, or maybe spread it out a little bit and extend it to 12 weeks, So these are all delivered via telehealth in kind of the same way, using sort of a Zoom platform there as well. So, you might be sitting there wondering, like, what idiot would think it's a good idea to teach meditation to a group of sleepy people, right? Like, that just does not make any sense. And so we thought about that. And our idea really was to bring about more of the movement meditations. There are different ways to meditate. You don't have to sit there, sort of in a lotus position, with your legs crossed. That's just one way to meditate. There's movement meditations. There's things like Tai Chi. You can even bring mindfulness to eating, so everyday activities. So we wanted to teach these concepts. And we were aware that, like, maybe sitting there, in a quiet activity might not be the best way to do this. So, we did do some modifications. And we're still in the process of analyzing the data. Since I've left Northwestern, I've handed it to Dr. Jennifer Munt. She's now in charge of it. And what I wanted to show you is we have looked at some of the qualitative data. So we did also do these exit interviews, so we got some qualitative data as well. So just wanted to read some of these out that I think are relevant for self-compassion. So this first person said, I like the breathing meditation and compassion meditation because I feel like I'm hard on myself a lot. People with narcolepsy tend to be hard on themselves. It comes with the stigma people give us. Okay, so I think that's quite powerful. This other person said, I'm less critical of myself for sleeping and taking naps. Okay, so that can be helpful for using that as a potential tool. And then this third person said, it's hard to be easy on ourselves, especially when the symptoms are perceived as laziness, to just put a hand on your heart and say, hey, this is rough, you're not alone, it will be all right. I thought that was really powerful. So again, this doesn't necessarily prove anything, but I think it's at least a first step into demonstrating that something seems to be at play here, right? This is what people are telling us. So, as we crunch the numbers, hopefully the numbers will also support this. And maybe by next year's conference, we'll have some of that ready to present. Okay, so just a summary here. Thus far, this is a work in progress. The telehealth delivery, for CBTH, I should say, telehealth delivery in groups appears to be optimal. It appears to be able to achieve a reduction in depressive symptoms, also seems to be able to improve self-efficacy. Again, this kind of goes to the idea of being more capable. For the mindfulness program, it's still early, but so far the qualitative data suggests that mindfulness practices can help with self-compassion. So in terms of where we're going, keep in mind that these are just early stage programs. We haven't proven that these things work yet. We just have demonstrated some evidence that it seems that we should take this to the next step. So again, just as a precaution here. And the next step usually is a randomized control trial or a clinical trial. This is really an experimental design that can help you detect whether or not something actually is effective. We also want to make sure that they're safe. So you want to make sure things are safe and effective, just like any drug. It also applies to psychosocial treatments. Also, we want to take maybe a closer look at for whom. We've combined narcolepsy and idiopathic hypersomnia because we think that the disease burden is quite similar, but there are some nuances. So maybe we should rethink that. There's some other ways we could split up groups. So, I think those are some open questions. And also, how should it be implemented? How do you train providers? How do you develop a scalable implementation strategy? So these are things that are actually I'm quite passionate about. And really, to be quite honest, that's actually what led me to leave academics and go over to industry, because I wanted to really try to figure out how to get these treatments into the hands of people who need them. That's kind of hard to do in an academic setting. We study it, we know it really well, but then we don't take the action of getting it to people's hands. That's what we really need to do. Okay. So just a quick shout out to all the study participants, some may be here in the audience who've participated. Our funding sources, Wake Up Narcolepsy has contributed, the American Academy of Sleep Medicine Foundation, NIH, the students and the collaborators. So none of this work would be possible without them. And I think we may have some time left over for some questions if anyone has any, for this first session anyways. And if you do have questions, I think we have a microphone floating around. Okay, yeah, I think there's a couple of microphones. Yeah, so if you have a question, if you can go to a microphone, that way everybody can hear you.
A question about what you term depression. It seems to me that depression is a big phenomenon, and not only, of course, for some narcolepsy people, but for me at least, there's a simple formula. If I'm tired, I feel down. If I'm energetic, I feel up. So why do you call the down part, which comes from the tiredness, depression? Isn't it something else? It's not based on, as far as I know, of course, I'm not a physician. No, it's not based on poor childhood or abuse or whatever. It has everything to do with tiredness and not tiredness.
Mm-hmm. Yeah, so thank you for your question. And I think what your question gets at is really It's complicated, right? I mean, depression is kind of a state. It's I mean, in terms of studying it, it's a mental health condition. So typically in a condition, you have certain criteria. You have to have some way to evaluate what it is. So to have a diagnosis of depression, usually you have to meet certain criteria. I think the point you're bringing up is sort of the nuance of like, okay, so it's one thing to be depressed because of some life experiences, right? But maybe it's another thing to be depressed because of some medical condition or some other factor. And so this is where we get into comorbidities, meaning like you have different conditions. So yeah, I think there is still this open question of like, depression in the context of narcolepsy or idiopathic hypersomnia. Is that the same thing as depression for somebody who had like a difficult childhood, maybe had traumatic experiences? I mean, I think in terms of the symptoms and the way that they would, they would respond to a scale, there are ways to say like, yes, there's a similar level of severity, but there's also some nuances. And I think those nuances are part of the reason, that the question we had to answer, which is why do we need a treatment just for people with narcolepsy? So our hope is that we can tap more into things that are relevant. Like I think in your case, it sounds like your mood is closely tied with energy levels. Okay, but that may not be the case for other people, whether it's other people with narcolepsy or other people who have depression without narcolepsy. So there's a lot of nuances. It's complicated, right? So I hope, does that give you at least some way to think about the issue that you brought up? Okay.
Try and talk to you later.
Okay. Yeah. Thank you. Sorry.
Hi. So first of all, I wanted to thank you for presenting some qualitative research. There is a long historical bias in favor of quant being kind of the be-all, end-all, but I think there's a lot, especially in a community where people's experiences are so different, there's a lot of value in the qualitative work. So I think that mixed methods research is really valuable for our community and for this field. I was also curious why, excuse me, among all the kind of schools of psychology out there, why CBT seems to be a focus with the narcolepsy community. It seems like there's something about it that folks think is a really good fit. It's what my therapist is using, and I'm happy. But I was hoping you could speak a little bit to either in your opinion or what exists in the research about why CBT specifically for narcolepsy and IH.
Yeah, good question. So, I think what you're getting at is, sort of CBT is an orientation or a certain framework that, for better or for worse, seems to be favored. Certainly in sleep medicine, but, with some of the work so far. So I'll give you a response, and I'll admit that, like, I'm trained as a CBT therapist. That's my orientation, so I'm going to be biased. In my opinion, CBT, I think, has more evidence. At the same time, the way that CBT is set up is more conducive to studying things like psychoanalysis. When you're talking about like repressed emotions and thoughts, that's very difficult to study. I don't know if it's impossible, but it's especially going to quantitative methods, it's very difficult to study. So if you're looking at evidence-based, that's one of the challenges with other orientations, whether it's psychoanalysis, psychodynamic. They don't have a strong evidence base, I think in part because it doesn't lend itself well to the tools we have to study it. Now, having said that, that's not to say CBT is the end-all be-all, and I think it'd be great if other people develop other types of interventions, whether it's psychodynamic, psychoanalysis, systems, family methods, things like that. There are a lot of other orientations that are available. So this is just, I would say from my standpoint, it's what I'm familiar with. It's, using the methods and the tools that I know so that we could try to demonstrate evidence, but it's not to say this is better than others. So it's not comparative, if that helps you. Yeah.
Thank you.
I was a participant in your mindfulness study and appreciate it. Thank you. I feel like
Thank you for participating.
Maybe I don't know whether I benefited from it immediately because I'm interested in seeing the results, but I do feel like I benefited from being introduced to mindfulness because after the study, I continued to look into that and start to practice that more, and I've found that beneficial. I was wondering how. Well, you don't know the results from this yet, but I wonder, mindfulness, it seems like, is helpful. I mean, it's coming to be a big deal, especially with the pandemic and mental health issues in the general public, and I wonder what the data is on how mindfulness with the general population is. And one thing about being in the study that I felt was probably helpful, like you had the better group effect for the cognitive behavioral therapy. I'm thinking the same thing for mindfulness, because it was just helpful to be in a group with other people. I hadn't met other people, with narcolepsy before, so I thought that was a positive for me.
Yeah. So, well, first of all, thank you for sharing your experiences, and thank you for participating. Let's see. So one question was the evidence for mindfulness kind of in general. Sounds like, across the population. There certainly is quite a bit, and now, we have apps like Headspace, Calm, and so forth, where people can get sort of bite-sized chunks of mindfulness that I think can be helpful. So, it's sort of interesting because, if you talk to someone who is trained in sort of the Buddhist tradition, like John Kabat-Zinn, who sort of is the godfather of the mindfulness-based stress reduction program, they never thought of this as a treatment. This is just a practice. It is a lifestyle. It is just something that you do. But now it's kind of taken, a different form. So it's kind of hard to answer. I think for things like well-being, there's quite a bit of evidence it can help with mental health, with well-being. In terms of treatments, it's kind of hard. People have adapted it, like we have for insomnia. We have a program using mindfulness for insomnia. We're trying to do it for hypersomnia. Obviously, there's people who've done it for depression. So I think there is a pretty decent evidence base to support the use of mindfulness, across the spectrum of health, whether it's well-being to disease. So in terms of whether or not it needs to be tailored or if it's some general program, I think there's still a lot to be worked out there. I think then your other comment and question was sort of about the group format, and it sounds like you're kind of getting at the social aspect of just, getting together with other people who have narcolepsy or idiopathic hypersomnia. I do think that's a pretty strong ingredient of this as well, and there's a part of me that if I was to design a control condition, I'd be a little scared to design one with just group social support, because I think that actually is going to be pretty strong from a scientific standpoint. But I mean, from a scientific standpoint, yes. From the standpoint of helping people, I think that social connection is really valuable. We heard a lot of comments of people that said, hey, this is the first time I met somebody else with narcolepsy. And that was really helpful for them. They felt like, oh, there's somebody else that I can relate to. This is more of a relatable condition. Before, I felt isolated. I thought I was the only one, didn't know how to talk to people, but there's others who've kind of gone through it. Yeah, so I do think that we'll need to eventually figure out from a scientific standpoint how much the social aspect contributes to this, how much of it might just be mindfulness, how much of it would be other specific CBT tools. Yeah. Thank you. Okay. Yeah, we could all use a little break. So yeah, please.
So it seems from your presentation that you're going forward, you have a pretty big philosophy around taking action with just moving forward with various psychosocial treatments. And I noticed in one of the studies you said you'd receive funding from the NIH, though I'm a little bit caught by surprise considering that even though sleep research, the NIH has expanded their portfolio over the years in sleep research, there's actually been a 44% decrease in funding specific to narcolepsy. So I'm just curious how you, going forward and wanting to, given all these studies you have and, just expanding this psychosocial, treatments and such, how, would go about that necessarily, given the fact that narcolepsy already is significantly underrepresented by the NIH and other institutions.
Yeah. So it's tough. I mean, I think your question sort of, gets at a little bit of like being strategic about how we can approach it. So the specific institute that funded our mindfulness program is the National Center for Complementary and Integrative Health, NCCIH. And so they're very interested in things like mindfulness, meditation. So that's, so there are these different institutes. In case you guys aren't familiar, NIH has these different institutes. So, for example, you've probably heard of one on infectious diseases. That's one that Dr. Fauci leads or did lead. There's also the National Heart, Lung, Blood Institute. They tend to fund a lot of sleep research. I think the challenge with narcolepsy is it hasn't neatly fit into any of those. So, and it's always been sort of this ugly stepsister that, like, okay, we understand a lot of people have it and they're suffering, but we don't really know what to do with it. Sleep in general has kind of fallen into that. This is where you have to be creative, right? And this is why, like, the first question I put up is the one that we had to answer to our peers and people at the NIH that are reviewing our grants. Why do we need a treatment specific for people with narcolepsy? So, the best way to convince scientists is with data. I could sit here and like record all of you guys and have videos and show them, but that's not going to convince them. So they get more convinced with data. And unfortunately, it's quantitative, usually not as much qualitative, but they're still starting to come around with that. So I think you just have to have a plan in terms of preliminary evidence. That's a big part of how you review NIH grants. So you have to have preliminary evidence. You have to have a framework. And so all these things have to come together so that it's compelling. So it is hard sometimes, just narcolepsy itself doesn't get a lot of funding. So when it does, it tends to go to the biological aspects of it. But you have to make a strong case then, like, well, until we find a cure, people have a high mental health burden, and that needs to be addressed. So you have to this is where it gets into grantsmanship and so forth. But actually, I sort of handed the reins off to Dr. Munt and others. I now collaborate with others because I've left academics. Part of it was actually the frustration of trying to apply for grants. You're basically as good as your next contract, kind of like an NFL player. If the funding dries up, then you're kind of screwed. So it's tough. But I don't think that's enough reason to give up. I so encourage and collaborate with others, and I know that there's others. In fact, there's other things in progress that are still continuing this type of work. So I just want you guys to know that even though I've left academics, I'm still trying to push the needle forward with some of these programs and research programs behind them. Yeah.
Thank you.